Broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Good morning to everybody on the West Coast and early afternoon for those on the East. This is Andy Dwyer with University of Colorado Cancer Center School of Public Health, working with Fight Colorectal Cancer to launch today's webinar talking about the goals of care when cancer is chronic with our key presenter, Dr. James Cleary from the Carbone Cancer Center. So we're super excited to have everyone joining today, and very excited about Dr. Cleary joining. So we'll go ahead and just make sure that we are presenting the slides, and we'll go ahead and get started. Just a quick round and introduction today in terms of ensuring that we're all set for today's webinar. Just a reminder that today will not at all replace your direct medical care or definitely replace any of the recommendations from your physician. If there's any time that you have an emergent situation, we recommend 911, of course. And we just want to remind everyone that, of course, today is for general education purposes, background, and to give a real broad spectrum of thinking about chronic care. And I think Dr. Cleary is going to spend some time talking about palliation and the like. So we want to just recognize that when you are keying in questions today, we really would like to hear your questions, thoughts, feedback. We'd like to keep them more general as opposed to one-on-one individual care or your direct medical questions, but really want to hear from all of you about your thoughts and the like. So on the right-hand side, there will be an opportunity for you to key in the questions and thoughts as we're going through today's webinar. So I just want to say a special, before we get to direct introductions and all, I want to say a huge thank you to the Fight CRC team who's really helping make today happen, with Michael Sola, Reese Garcia, and then also our social media team in the backdrop sharing tweets and information so that we can share the good tidbits and highlights from today's webinar. So we'll go ahead and go to the next slide, please. So just a quick reminder that you can follow along with our social media team, and that today's webinar, the slides will be posted after we're done presenting on the Fight CRC website, as well as all of the archived webinars from the past presentations. So next slide. And just again, here's a little tidbit that I mentioned earlier about your questions. So you'll notice on the right side of the screen, and then what's in front of you right now is front and center introductions about how to type in questions. Everyone is muted today, but we will have an opportunity for you to provide comments and thoughts throughout today. And then Reese will be facilitating this piece after the run of show today. So next slide. All right, just a quick reminder that Fight CRC has a variety of resources with the mini mags, which are a deeper dive into some of the specific topics. Right now we have specific areas like clinical trials, biomarkers, as well as skin toxicity, and a few others that really dive into some very specific topics with specific stories, case studies, as well as great information for you to provide to the medical team to think about comprehensive care. In addition, the Guide in the Fight, which is a tool for use during treatment, through treatment, really thinking about pragmatic and real life questions, even things around hospice and end-of-life care. The Guide in the Fight is one of Fight CRC's premier tools, and we want to remind everyone that in the last couple months we've done a refresh. So go to the website, download, or place an order, and we'd love to have you, and as well as your clinical team, if you can make any connections, making sure that we're disseminating all of these good materials. And a quick reminder also that we have the Tabooty podcast, where we really launch into some specific topics that aren't always necessarily top of mind, or even areas that people oftentimes feel openly comfortable speaking about. We'd like to bring those to the forefront and making sure that we're really talking about all of the critical issues for colorectal cancer patients and their support system. So just a whole bevy of resources. A quick reminder that they're all available for all of you and on our website. So just a reminder, today's webinar as well as these resources as well. Next slide. So now that we've actually talked about the whole repertoire of information and all, we'll go to the next slide, please. I'd like to actually introduce Dr. James Cleary. And just a quick note about the Carbone Cancer Center and Dr. Cleary. In our work with Dr. Dusty Deming as a medical advisory board member, we've actually, and even with our research advocates, we've had a great, now which is fairly long-standing over the last 3 years, great relationship with the Carbone Cancer Center. And we've had really good, in terms of integration of their team, working us through the Research Rats Academies, which is a training and teaching opportunity for our research advocates. Dr. Deming being very involved as a medical advisor and a patient liaison advocate, who's also going to be hosting our GI ASCO summary session. But in addition, we're really excited to have Dr. Cleary joining us, as Sharon Worrell, myself, and others attended ASCO last year and really got to hear a really provocative talk by Dr. Cleary about chronic management and care management. And we were really excited about a lot of the materials and in the way that he was actually able to tell the story based on his experience as an associate professor and director of the Palliative Medicine at University of Wisconsin at the Carbone Center. So Dr. Cleary, I think, has a fantastic resume, as you can tell, with the University of South Australia, working in that time, and then also of all of the work that he's done around his formal training in oncology as well as internal medicine. So I think we're really excited to have Dr. Cleary sharing the information about the work that he's done in chronic care management, and also the area of palliation, which we've spent a good time with Fight CRC providing in the number of resources, included those such as Guide in the Fight that was mentioned today. So Dr. Cleary, if you are ready, I'm going to hand it over to you. And just a quick reminder, everyone, to go ahead and type in those questions real time for Reese to facilitate at the end of the call. So Dr. Cleary, are you ready?
I think I am, if you can hear me.
We can hear you beautifully, the wonderful accent. So you are all set to go.
Well, it is. And for those, thank you very much for the introduction. And for those of you who watched the Super Bowl last night, you clearly know the value of having an Australian at the party. It really was a great commercial that featured Crocodile Dundee again. Not sure about the Yellowtail commercials, but that's a different issue. It's not often one gives a talk at ASCO and gets asked to give a number of other flow-on talks from it. But that's been the result of the presentation that I did just on 6 months ago, 8 months ago now. And I do want to give out a shout out to Dusty Deming for the context that he's set up. One of the things that we often get accused of, and I say accused, as palliative care physicians, is all we do is talk about death and dying. One of the things that I particularly find is that I go into a room and ask people who have advanced cancer, what's on your mind? What are you thinking about? And it's actually the patients who say, I'm worried about death and dying. And so it's that elephant in the room. It's that taboo subject that cancer doctors don't want to talk about, some patients. So while we're going to talk about some of this today, what I really want to do is address some of these issues of goals of care as they stand out. And we'll change a slide. There we go. So it's really, I don't have any conflicts of interest. This is re-establishing goals of therapy in cancer care, exploring issues of informed consent and issues of hope that we'll actually be talking about today. Yeah, ASCO does bring great research, and it's again, I'll make this inference that it's described as the Super Bowl of cancer research. And as much as we're talking about FIGHT, CRC, colorectal cancer, this whole notion of fighting is one that we may get to discussing as we move on, and the whole concept of living with as opposed to fighting cancers at this stage. And for those of you who are of my vintage, I grew up in Australia with this young lady as being a top fan, or I was a leading fan of this young lady. Many people aren't aware that she actually was in the Eurovision Song Competition representing England. She was a good country singer until she met John Travolta and did this sort of stuff with Grease. But more recently, she's been on a tour of the United States looking at this live-on music that inspires gratitude, hope, and healing. And she's been doing this with a number of colleagues. But it was actually while she was on this tour that it was announced that she had to postpone the tour because she was diagnosed with recurrent breast cancer. The cancer had actually metastasized to her sacrum some 20 years after her original diagnosis. So this comes back to some of the issues of what's really going on in the care of patients. Surely Olivia Newton-John was cured and now she's not cured. Is that the language we should be using in this setting? And so we often hear, and just last week I was at Grand Rounds at the Carbone Cancer Centre, and we had a hematologist who kept talking about palliative chemotherapy that prolongs life a few months. And I think it's really very, very important that we understand the differences between these. And I do engage in social media, at JF Cleary Whisk on Facebook. Sorry, that's Twitter. At JF Cleary Whisk on Facebook, and also on Twitter and also on Facebook. But here's a tweet from an oncologist. Easy to say, but as an oncologist, my role is as a warrior against death. End-of-life discussions, completely different role. And one of my colleagues, Christian Sinclair, engaged with this oncologist. But I think it's very significant that we actually do raise these issues. Is it the elephant in the room, as I mentioned? So let's get some clarification of what we're doing. This is a survival curve. And on the y-axis, we have percentage survival. The x-axis is years. The black line is the survival curve with the disease, the normal population in the blue. And the reality is that's not a straight line, the normal population. It's a curved line, but I can't really do that properly on PowerPoint, so that's why it's a straight line. I just want to point out, this is from The Onion, satirical magazine that started here in Madison, Wisconsin. The world death rate is holding steady at 100%. So the reality is 100% of us are going to die. And the reality is we still don't talk about it. There are many people say they don't want to die, but the inability of doctors and scientists to adequately address this issue of death is nothing less than a scandal, said a parent. I do believe in total decomposition of the corpse as a result. And this is facetious, it's joking, but it is actually a reality in life. And how do we normalize this process? But a disease is cured, not an individual. A disease is curable if, in fact, the people with the disease don't die of the disease. So this is a population health diagnosis. And many people living with cancer say, oh, but I want to use that cure language. And there may be challenges with this, and that's one of the issues that I'm going to bring up. So here we have the normal population, and then that second blue line actually shows the population. Yes, there may be some deaths early from therapy, but then they live at the same rate and they don't die of that condition. And very early colorectal cancer is one of those diseases that now actually meets that criteria. If we can catch these very early, the population of people with that disease are going on to live a normal survival and normal lifespan. But as much as we have the war on cancer, here's a story from the New York Times that actually says, hey, we've had this war on cancer. We've got now the Biden initiative, this advances elusive in the drive to cure cancer. And I would argue that much of what we do in cancer medicine at the moment is prolonged survival. So we can see here the solid blue line with prolongation of survival really could be a matter of weeks or could go out to entire years. And we now see that with colorectal cancer, people who have resection of liver metastases are living a long time without recurrence of disease. But as a population as a whole, there is still a risk. And this is one of the things that I would put Olivia Newton-John in, that with the breast cancer she had, there was always a risk that her disease was coming back. And while she had no evidence of disease, clearly those seeds of metastases were sown from the point of diagnosis and were there. I was talking recently to a group who runs, a woman who runs an online support group, and they have little towns of community. And she actually said they have a town or village, an area where people go for the netters. No evidence of disease. they don't even in that support group population use the concept of cure. They are talking about no evidence of disease. And that's really all we can say. It's fascinating when we look at the pathology, an area the size of a pinhead, which we can't see on CT scan, has 1 million cancer cells in it. And so it is actually, yes, these seeds can be sown. It may take 20 doublings. Cancer cells double every a period. Some double every day. In the case of a Burkitt's lymphoma, some colorectal cancers may not double or may double every 6 months. So it may take 10 years to go from one malignant cell to that pinhead, 1 million cancer cells. So it's important to understand some of these issues as we move forward. And then how do we cope with living with this situation? I'd also put it to you that much of what we do in oncology actually has little impact on survival, and this is particularly true in very advanced disease, when people are bedbound, when people have comorbidities, other diseases such as lung disease, heart disease, dementia, and other conditions. Our primary focus becomes one of making sure people are comfortable. So this article released last year says, why does this make this whole issue so frightening? Well, here she is diagnosed many years ago with no evidence of disease, and now this cancer comes back. How do we live? How do you cope with this, the possibility that this may be happening as part of our lives? It's interesting as you look, and this is an article which confirms many of the things that I've been talking about for years, and they define the different chemotherapies that we do rather than just curative and palliative. So they bring up this concept of curative chemotherapy, and that's very true for testicular cancer, Hodgkin's lymphoma, some very early breast cancers, some very early colorectal cancers. But then if we look life extending therapy, it says the intent is to extend survival, but not long enough. But let me, before I go on to the life extending, this is an example from breast cancer. And what it shows is survival curves. And this is from pooled Dutch data with over almost 200,000 patients. And we can see here that the survival curve for the very, very early, the N1 and the N0 up in this region, are getting flat. They're not flat down here for the N2 and the N3. So these are populations of people who they're still at risk of the disease coming back. And this is also true when we look at, this is a somewhat shorter follow-up period, but it's the same applies in these conditions, that we actually see that the curves are not flat. And what you want for a disease to be curable is for the people with those disease not dying of their cancer. Somewhat facetious headstone. We once were where you are. You will be where we are. Prepare. This goes on then to life extending therapy. The intent is to extend survival, but not long enough to meet the definition of cure. Some people use 5-year survival as a definition of cure. That has been used in the past for pediatric malignancies. But again, Olivia Newton-John's story shows that 5 years is not protective. So we have to be careful of using those. Just excuse me. And it gives examples of therapy that can be used. Volfox and bevacizumab, life extending therapy. And then so these are again important expectations. This is a study done again from Massachusetts, and I think it's very significant because what it did was it actually asked patients what their expectations of therapy were. And you can see from the results down the bottom, 81% of those patients with colorectal cancer did not report understanding that chemotherapy was not at all likely to cure their cancer. So these are people with metastatic cancer. Their physicians have supposedly talked to them and consented them and said, here's the intention of therapy. but most of them did not understand what the goal of therapy was. And here we have the colorectal cancer patients in the blue. What is the likelihood of a cure, life extension? And we can see that there seems to be a misunderstanding, and we have something like 70%, close to 80% of the patients saying it's likely that they're actually going to get a cure for their disease. Symptom relief comes down. We can see that, yes, that's a good thing, but it's that misunderstanding. It may be what people wish for, but really we're asking, what is the reality of your therapy? And if you have metastatic colorectal cancer, the likelihood of a cure, based on the definition I've given you, is actually very low. Then we come to palliative chemotherapy. The intent is not to cure. It's primarily there to improve quality of life. But then it's important with palliative chemotherapy that we balance the side effects versus the potential goal. If the goal of palliative chemotherapy is to reduce symptoms, improve your quality of life, and you don't actually have any symptoms, why do we go ahead with chemotherapy? And that's an important question that we have to be asking. If in fact you have some pain, and particularly liver metastases, yes, shrinking the liver metastases may actually result in significant palliation. But I can do that with steroids just as well as I can with chemotherapy, if not better. And particularly if there's no intent to prolong survival, using steroids and opioids may actually be a better therapy than yet another line of chemotherapy that may have all its side effects associated with it. I have enjoyed this article very much, or document from the Institute of Medicine, which was called Improving Palliative Care for Cancer, released in September 2001, so it didn't get a lot of publicity at that stage. But it talks about the different things that make up palliative care. Many of us think that palliative care is just care of the imminently dying, but I'd put it to you that it's all these skills that are an important part of what we do. Advanced care planning, managing symptoms from disease, symptoms of therapy, psychosocial issues, including bereavement, and they all come together with care of those who are imminently dying. This is the diagnosis of palliative care from the Center for the Advancement of Palliative Care in New York. And it really becomes part of the treatment of any person with a serious or life-threatening medical condition. Patient-centered, pain and symptom control, family involvement, compassionate care. And this is really synonymous with good medical nursing care involving all healthcare team members. This is another way that my colleague, Dr. Campbell, has actually painted the concept of palliative care. And I think we rely a lot on the physical, and our entree into the room is often through the physical. So absolutely critical as we move forward, psychological, social, spiritual, and existential, all important components of the care. And it doesn't take much as a physician to actually get into the spiritual and existential. Many of us as physicians are, I'll say, a little trepid about going here. But even asking a question such as, how does this, what's happening with you with cancer, fit in with your views and meaning of life? Or I'll ask the question often, how do your spiritual or religious values impact the way you're coping with the disease? I don't have to answer questions. I'm just asking them. And really, as Dame Cecily Saunders, the founder of the modern hospice movement, so often said, listen to your patients. They have the answer. Rather than talking to patients, we need to be talking with patients. A very, very subtle difference that becomes so important. We've been working on communication for some time. We had a National Cancer Institute grant to develop this system, which was called CHESS, Comprehensive Health and Cancer Enhancement Support System, web-based. We gave information, we had support groups online, and different tools that may actually help people. This program for lung cancer. And here's all the information that we would provide for people. They could click on these links and they could find things out. No one was forced to look at it. But again, just like Amazon, if you realized people were searching for topics, you could actually start feeding them back information saying, I saw you were looking at this, maybe you'd like to look at this web page. We also included in this a number of things where both the caregiver and the patient could report their symptoms. And this actually then was fed back to the clinicians in a clinician report. And at any stage, someone ranked a pain score of over 7 or 7 or above, an automatic report was generated to the clinic. We didn't tell the clinic what they had to do with it, but what we found was that the clinic staff started calling patients when they knew someone had poorly controlled symptoms. So we got on top of this much, much sooner than we would have if we just waited for them to come to clinic. The other thing that we did was ask them to document their needs based on the distress course that Jimmy Holland had developed, and also ask them to put questions that they would want to be addressed at the next clinic visit. So here you can see a caregiver saying, what are the options if the current treatment doesn't work? Can someone help me with family leave? And often the nurse who saw this was generated, sent to the clinic before clinic visits. You could actually see, and people would address these issues, and he'll actually allow the oncologist and the clinical team involved, and increasingly the palliative care team, to actually address some of these issues as they move forward, rather than the family and the patient coming out and saying, well, we got our 15 minutes, but none of our questions were addressed. So this was just recently published in a report in Cancer, which actually showed the impact of the healthcare system of this e-health system, and lots of numbers, but we actually showed an improvement of a reduction in distress. Statistically significant? Yes, it was. Is it that clinical significant, dropping people down 5 points on these out of 35? Maybe. We think any reduction of symptoms is probably valuable, but we would have probably liked to have seen more than just 5 of the 35 points. But significantly, we showed, and there's 2 graphs here. The first graph shows that there wasn't much difference between those who used internet alone versus chess. That turned out to be a non-significant data. But when we actually look at the people who use chess as opposed to the non-users, we actually saw there was a significant improvement in survival from this internet-based system. And people start saying, wow, that's pretty significant if we can show that through monitoring over the internet, these sort of clinician reporting, hopefully a reduction in symptoms, that we showed an improvement in survival overall. And this comparison is very similar to the results for non-small cell lung cancer. We don't have this data for colorectal cancer, but here was Jennifer Temmel's famous study actually supporting early palliative care clinical interventions, and our survival curve was very, very similar to what we may actually be showing here overall. Them having clinical visits, ours with the internet, but we show that palliative care and attention to detail with symptom management and other issues results in an improvement in survival overall. More significantly, I think, rather than the survival benefit, the reality is that early palliative care doesn't end up in a sooner death, or we're not bumping people off. And that's always a fear. If I sort of focus on palliative care, end up on hospice, I'm going to die sooner. No evidence that that is the case. And I think part of this comes with the words we use. There is nothing I can do. I use an example where a colleague said once, well, we could do surgery, we could do chemotherapy, we could do chemoradiotherapy, or we could do nothing. And I said to him afterwards, you just called me the director of nothing medicine. Palliative care is not nothing. We talk about withdrawing care. We never withdraw care. We may withdraw anti-cancer therapies or say there are no more anti-cancer therapies, but this concept that there are no more treatments. There may be no more treatments directed at the cancer, but we always have many therapies, treatments that we can do to focus on people's comfort symptoms. Failed therapy. Patients don't fail therapy, students fail exams. I had a colleague here who said she would not want to be considered a patient in a healthcare system that considered her a failure. And I think this is language we need to get out as treating oncologists. But for those of you who are patients, I wonder how many of you have actually heard these words. We have salvage therapy. And again, grand rounds last week at the UW, I heard this language. But what do we salvage? We salvage wrecks. Our patients aren't wrecks. So we need to be looking very, very carefully at the language we use. I mentioned earlier this talking with patients rather than talking to. I very rarely now, where I've tried to get out of my language the word happy. I would be happy to care for you. What does a patient or a family member think when I use that word happy and what it means? There's nothing happy about this situation. So I would now say I'd be very comfortable, I would be honored, but it's just being very careful with the language that we use because we're not on the receiving end and there may be many implications to it that we're unaware of. We often talk about patients and we say the patient refused therapy. Children refuse things, they refuse to eat their peas or vegetables. Patients may decline to have a therapy. And it's getting to that sort of language rather than putting it into this confrontational thing, refusing to have therapy. And then we often talk a lot about hope. I don't want to take away hope. I'm just going to show this. I think hope it will project in the volume. This is a very powerful video from Atul Gawande, and it was really the writings about Sarah that took him down this path of exploring issues related to palliative care. But I think that, you know, when the husband actually says, you know, you joined in our collusion of hoping for the best. One of the things that my father taught me in a paraphrase of Mark Twain, if you tell the truth, you don't remember what you said. But I think we as oncologists are very worried about telling the truth for fear that we may actually take away hope. I'd put it to you that in order to give informed consent, and you now probably have all signed consent forms for the different therapies, be it surgery, chemotherapy, radiotherapy, it's truly understanding what's going on. And the informed consent includes reasonable alternative to the proposed and actually includes what if I don't have therapy? And we need to be talking about those options. And I've heard oncologists actually say, well, we all know what the alternative is. Next topic. We need to be exploring those in a meaningful way so that people are truly making informed consents. And how much information is adequate? Reasonable, what would a typical physician say? Well, if we use the typical, we know that that's not being done well at the moment, so that's probably not a good standard. What would the average patient need to know? So the patient standard may be in part of that as we move forward. And then what would this particular patient need to know and understand in order to make an informed decision? And I think it's those latter two, and particularly in the bottom one, as we tailor information, some people may need a lot more information before they actually agree and consent to the different therapies that are going on. And this includes side effects. No one told me that I get a rash from this therapy. No one told me I'd be so fatigued. So it's understanding many of these issues as we move forward. So it comes back to this question that what do we do as oncologists? The palliative versus curative, I would add in there the life-prolonging therapy that we would move forward. One of my colleagues actually says that we as medical oncologists are often giving hope in plastic bags or syringes. This is a somewhat older slide, but at that stage it was sort of hope at $4,200 a dose. Now we know with some therapies that it's hope at $100,000 a dose as we try to tailor-make different therapies and the issues around this. I think it's very interesting to explore what hope is. This is Pandora and Pandora's box. And it's actually interesting as everything left and she finally got the lid down. What it was hope was left in the chest. This is a story from Greek mythology. So hope is essential to the human spirit, inextricably connected to suffering overall. But it was hope was the one value that was actually left in there. So people have talked about the due value of hope. This is an opinion from colleagues out in California on hope. Focused hope provides indispensable support. Concentrating on the outward tangible goals such as cure and recovery. I would, though, focused hope, maybe not the word, are these wishes? We need to look carefully at the language. Here he talks about intrinsic hope. Intrinsic hope centers on subjective personal issues, hoping not to be a burden or to give or receive love and relationships. So it's changing that focus. But I still struggle with some of these words that they used for hope overall. Wendy Harpham is a physician who's actually had a low-grade lymphoma. She's been treated many, many years, and she writes in Oncology Times, for any of you who have the opportunity to get hold of this. It's a newspaper type journal, and she talks about some of the issues, realistic hope versus wishful thinking. And she does it with, because she comes from as a physician point of view, she's actually able to weigh up some of the issues that are so important all around in terms of being able to compare the different therapies that may be out there, and making sure as she looks at some of the alternative therapies that are offered, are they really weighing up as we move forward, or are people just selling us false hopes? Probably the most important document that I use is this one by James Tolsky. James is now in Boston, he was at Duke, and he wrote this wonderful piece on hope or hubris. And here's the different definitions of hope: trust, reliance. The second is a desire. And it's important to look at these in terms of this concept. And most of the times we use the word hope, it's in expectations. Someone or something on which hopes are centered. Desire accompanied by an expectation or a belief. I hope it doesn't snow. I hope that I win the lottery. It's all these expectations. And we use this language about cancer. It's very difficult in the cancer setting if people have expectations. And I've had patients who've said to me, well, I want to see my daughters graduate from college. And they've got metastatic cancer and they say, well, I hope to see my daughters graduate from college. How old are your daughters? 2 and 4. Is that an unrealistic expectation? It's a wish. So I explore with people, and when people say to me, I can always hope, or we can hope for the best, I actually ask them, what do you mean by the word hope? And what Tolsky goes on to talk about in terms of the primary definition is trust and reliance. A hope-filled person trusts that whatever the outcome, good or bad at first glance, will ultimately be for the best. I had a friend, a father of some of my children's friends, and his wife was dying of cancer, and one night we were out bike riding and he was coming the other direction. He saw me, and soon he turned around and we were riding down the road at 25 miles an hour, and I could hardly breathe, and yet he was having a full conversation. His adrenaline was flowing, and he said to me, you know, Jim, this sucks. My best friend's dying, my wife's dying, my kid's mother's dying, but you know what? Things are going to work out. And I would feel that he was one of the most hope-filled people in that situation that I've ever come across. And yes, now he's remarried, his kids have grown, things have worked out. They weren't the way he thought they would be, but it's this trust and reliance. And this may be in a religious context, but can be totally secular in terms of faith and community. So Wendy actually goes on to discuss some of these issues as she moves forward as we live with the issues of chronic illness. Is the cancer coming back? And she put some quotes in. I found the cure for fear of recurrence. Go ahead and have one, then you'll stop worrying about it. And recommendations to oncologists. Your patient is in remission. You've done a great job, so celebrate and prepare yourself and your patients for the possibility of post-treatment challenges, which can include recurrence, and keep you on your toes. This whole concept of the chasm of cure, it's something that we're all sort of talking about, whereas let's not use that language. The no evidence of disease, we don't have any guarantees that you're going to be curable. Talking about a disease rather than individuals being curative, I think become very, very important. She goes on to say, care is a continuum. The ultimate goal is not always getting rid of the cancer forever, but healing the patient in front of us with expert and compassionate care. Everyone benefits if we remember our roots and see a cure as part of our broader mission to care. Hope does not lie in a way out, but in a way through. I'll stop there and answer any questions that you may have. Thank you.
Thank you, Dr. Cleary. That was a very wonderful and informative presentation. This is Reese Garcia, the Research Advocacy Manager with Fight CRC. And we do have a few questions that were sent in. One of these was wondering specifically how some doctors equate palliative care with hospice. Based on your experience, is this changing, and has this been the case?
So yes, it is changing. And I think that's actually an important thing to remember. It is changing overall. The primary provider, though, of palliative care in this country for many years was, in fact, hospice. And people say they're different. They are different, but they're the same. All hospice is not palliative care. Let me get that right. All palliative care is not hospice, but all hospice is palliative care. So palliative care has been a provider, and because of Medicare limitations in the United States, it is restricted. But what the palliative care programs in the teaching hospitals, the cancer centers, have actually been doing is bringing palliative care out of the palliative care box. Hospice palliative care has really become brink of death care, with the median length of stay in a hospice, not just the building, but at home with hospice, is something like 17 days in the United States. So 50% of people who get referred to hospice in the United States die within 17 days. That's brink of death care. And what we're really doing is saying, no, 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 it shouldn't just be brink of death care. This is something we need to be doing much, much earlier, and that is changing at the moment around the country.
Wonderful, thank you. In terms of, you mentioned Medicare and Medicaid, does insurance typically cover palliative care, and what have you seen challenges with patients getting palliative care covered?
So when you say palliative care being covered, we would argue that most patients are actually receiving some degree of palliative care when they go to a cancer center. Whether they've seen a specialist or not becomes significant or engaged with the palliative care service. In fact, Medicare will actually pay for palliative care physicians. They're not necessarily paying for the full team, but then institutions are working out how they can actually do this. Cancer centers, oncologists, how do we engage palliative care clinicians? And they're finding out either through cost avoidance or improved quality of life, reduced hospitalizations, and other such things that the whole system can actually afford to provide palliative care rather than putting this full focus back or the payment directly on the patients. So it's a complex issue as we move forward, very much caught in models of payment. As we look at the different models, accountable care organizations and things, I stress that the primary focus for doing palliative care is not cost savings, But one of the ways we can justify it to our administrators is that at times we can actually bring about cost avoidance and therefore justify appropriate palliative care through not giving inappropriate chemotherapies and other such things. I hope that answers that question.
It does. And so on that note, you mentioned that most cancer centers in some regards offer forms of palliative care. What do you recommend a patient does if they find that their doctor isn't necessarily offering them palliative care to their standards, or they want to explore additional options?
Ask for it. I think it's very, cancer centers are increasingly, or particularly NCI-funded cancer centers, we've got the data that this is coming up in other cancer centers now that aren't necessarily NCI funded. People are saying that this is, excuse me, people are actually saying this is a very important part of what we do in the care. So I would ask for it. Ask the different nurses. You can call the cancer hotlines. You can look online as to other centers, but say, I think this is an important part of what I should be doing. We did some focus groups with some oncologists in the past. And one of the questions that, or one of the comments we heard from an oncologist was, I feel that the family knocks me off my pedestal when palliative care becomes involved. This is an oncologist. And I like to remind oncologists, this is not about their ego. This is about making sure that the patients get the best care possible. Meeting someone who's going to focus on pain control, address other significant issues, and it's not just a doctor, it may be other members of the team. I actually feel that some of my colleagues are excellent palliative care physicians. These are oncologists. They don't need me in the room as another physician. They may need help from a nurse or a social worker or even a chaplain to come in. So the primary goal that I see a palliative care team is doing is filling in the gaps that may exist in the overall cancer care. And many, many oncologists, don't get me wrong, are very, very good at addressing the total care of patients. They see the big picture. They know when to say enough is enough. One of my colleagues says very early on in the care of people with metastatic colon cancer and pancreatic cancer, I'm going to give you therapy. We're going to go ahead with chemotherapy, but there may be a day where I come and say, you know, there's not more therapy. And he raises this from the word go. And so, and every time they talk recurrent disease and more therapy, remember we've talked about the fact that no more therapy is an option. You have every right to actually say, I'm at that point now. So I think this is just sensible dialogue rather than just thinking that because we're trained to give chemotherapy that the only tool in our toolbox is in fact palliative care. Sorry, is chemotherapy.
Well, thank you. That's great insight. And in the interest of time, we have one more question. Do you have any thoughts on the use of alternative treatments such as CBD oil for patients, or have you seen that in your line of work as being beneficial?
So we're talking about the cannabinoids, marijuana, the different oils. So one of the challenges we face is that we've not really done the same caliber of studies that we would normally associate with approval of these different medicines. There are people in Israel who've done some of these studies, and they actually have nebulized cannabinoids available in Israel now, and there's some evidence that it has improvement in pain control. There are studies being done with various forms of cannabinoids by pharmaceutical companies in patients with cancer out of the United Kingdom that have not shown an improvement in pain relief. And it may actually be that they took out the wrong strains of the cannabinoid and tested them. So I think as much as morphine is a natural product, as much as taxanes and many of the chemotherapy drugs come from natural products, there is no reason not to believe that the cannabinoids, products from marijuana may have a medical benefit. And I think we need to be doing more research on this. The reverse is that there are many people who favor the recreational use of cannabinoids, and they're basically telling regulators and others, no, let's not put it in the hands of the pharmaceutical industry. Let's just allow anyone to use that they want to. I would actually like to be able to do or to have the research that shows the benefit and when to use it exactly. So I'm not dismissing it as a potential benefit. And at the moment, many states actually allow the medical use.
Well, great, thank you. So it looks like we're right about at time. So Dr. Cleary, once again, thank you for taking the time to discuss palliative care and how that fits into the role of treatment and chronic. And for all of those listening in, the recorded version of this will be available at fightcrc.org/webinar. And then, as always, contact us toll free at 1-877-427-2111. And we appreciate you all taking the time to listen in. Thank you.
Thank you very much.